Hello, everyone, and thank you for joining us today. I'm Barney Gill, and I help with our education curriculum here at Beam Readers. I'm excited to kick off the first in a planned webinar series by Beam Readers oral and maxillofacial radiologist, sponsored by Vatech America. I'm honored today to introduce Dr. Julal Bukhari, who's one of our cherished team members. Our goal here at Beam Readers is to help you be successful and get the best actionable information from your 3D imaging. Dr. Julal Bukhari is one of our nearly 70 oral and maxillofacial radiologists that are experts in unlocking the information within each scan. Today, Dr. Bukhari and Director of Education at Vatech America, Jim Mayer, will have a discussion about going through a CBCT scan and items to consider when imaging a patient. We hope this moves you further along in your understanding of evaluating 3D image volumes and the clinical correlations. This gives a glimpse to the depth of knowledge and expertise that is applied to every scan we read. We're offering 1 hour of CE credit for those of you that are joining us live today. Please make sure you stay on for the full hour to earn the credit, and to take the survey, we'll email you afterwards. Then within a week or two, you'll receive an electronic certificate from me and our CE partner, Big Sky Seminars. To ensure we clearly communicate everything today, we did pre-record this webinar. Dr. Bukhari and Jim Mayer are here online with us now to answer any questions in real time, and Jim will provide instructions on how to chat with us during the presentation. If today gets you excited to learn more, please come register with us at beamreaders.com and see how an oral and maxillofacial radiologist can support your practice by reviewing and providing a second opinion on your CBCT scans. Also, please check out our other educational offerings on our website through the drop-down menu at the top of the page. If you have unique educational needs relevant to CBCT, please don't hesitate to reach out to us directly at education@beamreaders.com. Now we'll get the presentation rolling.
First of all, I want to thank you, Barney and Beam Readers, for organizing this event and helping us put this on for everyone. And Dr. Bukhari, thank you. I want to thank you for your time and effort and dedication to this session today. I think we've got a lot of great information for our participants in this session. Before we begin, please note on the upper corner of your screen, there's a chat feature. This allows you as a participant to chat with us as we're going through this session. Dr. Bukhari, thanks again for being here. It's been great working with you on this project. I think we've learned a lot about each other and really about the needs of our doctors in the field.
Absolutely. Thank you so much for having me. It's a pleasure to be here. And, whatever we can do together, I think would benefit not only each other, but other people who are interested in this wonderful field of radiology and how it can benefit them in their practices.
Diving into some of the bullet points that everybody can expect today is, what defines an FOV or a field of view? Let's look at some clinical applications of what we can capture within each of those fields of view. We're going to provide some examples. There's always that concern of radiation dose, right? Of what is the dose? Patient care, right? Patients want to know. But I think you're going to, talk a little bit about that and how do we address those concerns. Other things we bullet pointed for this is understanding what we're seeing in cone beam software, reading a volume of axial, coronal, sagittal. So you're going to take us through a overview of methodology and workflow and why are we doing that. On screen you can see a few fields of view, from large field of view all the way down to a smaller field of view of 4x4, 5x5. Dr. Bukhari, I know you have a passion for OSA, airway, TMD, TMJ. Let's start with a larger FOB, and in this case, we have an 18x15. What are some of the clinical indications that we may use this for?
Absolutely. So as you mentioned, Jim, thank you. The field of view, it's pretty much defined as I mentioned, the size of what we're about to take, we're about to image. And it's the diameter into the height. So on the screen, you can note that it's a cylinder, which is capturing the the maxillofacial structures. So it's either represented in millimeters or in centimeters. So if you look at the top right portion of the image, you'll see the 18 by 15, which is quite a large field of view. You'll capture all of the maxillofacial structures at least, and portions of the skull as well. Now, this being the largest field of view, at least on this table, and what the machine probably has to offer, you can capture a lot. Obviously, you can go all the way back to the mandibular rami, the posterior borders of the rami. You can capture both the arches, portions of the head. And this is great for clinical implications, which include especially orthognathic surgery. If you have surgical guides that you need to use for multiple significant implant therapy for full mouth reconstructions, typically orthodontists and oral surgeons will use these larger fields of view in complex cases, which there needs to be some kind of reconstruction specifically.
Let's talk a little bit maybe about the 12 by 9 field of view here.
Absolutely. No, great point that you mentioned, James. I appreciate that. And, the whole thing is that you want to acquire what's absolutely necessary. Now, in the cases, as I mentioned, for complex surgeries, you might need a larger field of view because you're going into surgical intervention. However, if you are looking into, say, multiple implant therapies in the maxilla and the mandible, right? You want to capture the lower border of the mandibles so that you can easily measure the inferior alveolar nerve canals, the mandibular canals, and portions of the sinus, if not the entirety of the maxillary sinuses, in case you want to plan for, let's say, sinus lifts or bone grafting in the maxillary arches. So a 12 by 9 will capture, a significant portion of the maxillofacial structures, good enough for you for a practice to basically delve into implant therapy in both arches. And you want to, again, I can't stress this enough, you want to take what's absolutely necessary. There's no point in, if you're looking for a single implant therapy, a 4x4 or 5x5 should suffice. That's all the information you need, as opposed to taking a 12 by 9 for a single implant therapy.
So let's talk more about that smaller field of view, that 4x4, 5x5 single tooth capture, 4 centimeters or 5 centimeters.
Absolutely. And you're absolutely right. So let's take, for example, you are taking a small field of view for the purposes of endodontic therapy, right? You're taking a 5x5 on a single tooth, let's just say the maxillary canine, right? By taking that small field of view, you are gaining a lot of detail, as opposed to if you were to take a 12 by 9 or 16 by 9 just for those same purposes. It goes into the details of radiation physics, which I won't bore you with, or even in the beginning it flew over my head. But just remember, the smaller field of view that you take, right, you're gaining a lot of detail.
Let's talk about radiation dose, and I will let you kind of start the conversation here.
Sure. So firstly, it's important to know what we mean by dose in radiology. So radiation dose is a measure of how much energy is absorbed when something or someone is exposed to X-rays. And this is important because it's the absorption of the amount of energy that can cause damage to a person. The harmful effects of radiation and the risks involved with its use considered when using any type of X-ray device. I usually go back to a report that was generated by the National Council on Radiation Protection and Measurements, also known as the NCRP. And they said that the average annual radiation dose to a person in the United States is 6.2 millisieverts. Now, sieverts is being the measurement for the radiation dose. And approximately half of this exposure comes from medical exposures. Now, exposures, when we get into the dental field, right, only contribute a very small portion, around 0.14% of the total annual exposure, or around 0.26% of all that's coming from the medical or consumer products or other sources. So even though it represents a small percentage, The reports also mention that there has been a slight increase in the total exposure when comparing previous reports. So even though it's less, it's increasing with time. So that means, the modalities are getting out. There are, more people are taking them. And even though we have, we have great machines which minimize the dose to the patient, nonetheless, we're taking more. I think that's what the report says. So we have to understand that the primary risk from dental radiology or any type of radiation is the unlikely chance of radiation-induced cancer. Now, there's an extensive body of literature linking relatively large exposures of radiation, such as those from the survivors of the atomic bombings. However, there's a great uncertainty regarding the risk from low-dose diagnostic procedures, such as those in the medical and dental field. Analysis of the literature has led us to the development of what's called a linear non-threshold hypothesis. Now, again, this is a hypothesis, remember. But in the most basic of terms, if you want to take it, right, it explains that there's no threshold or no safe dose below where there is no added risk. And there's a linear relationship between the dose that a person receives and the risk of inducing a new cancer. Now, this information might seem scary, right? But again, we have been given the responsibility to do no harm to our patients. We're professionals, we're medical professionals, right? And we have to put this responsibility into our hands. So even though we have these modalities, we have this machine which gives off radiation, we have to use it to the best of our knowledge and responsibly. So, keeping that in mind, you don't want to obviously scare yourself or scare anyone else, but this is one of those truths that we have to basically live with. And the best thing that you can do, right, is to image responsibly. Take what's absolutely necessary, know your machines well, to, look into the precautions, all those kind of things, right? So even though dental radiography, like the radiation that a patient's being exposed to in dental radiography is low, once a decision has been made to obtain radiographs, it's our responsibility to follow what's called ALARA. We call it ALARA, ALARA, as low as reasonably achievable. And this is to minimize the radiation exposure to the patient. One way by doing this, take the field of view that's absolutely necessary. So the dose is also dependent on other factors, some of which can be controlled by the CBCT machine and the operator. And some machines actually provide low dose settings to minimize the total dose that a patient can be exposed to. One of the resources that I believe that we have as dentists is the ADA website. Now, a lot of you may know or may not know actually that the ADA actually collaborated with the FDA back in 2012 to come up with a paper, right? And they developed recommendations for dental radiographic examinations to serve as an adjunct to the dentists on how to best use diagnostic imaging. It's a great resource that every practitioner should refer to, especially when trying to decide what image should I utilize or how can I limit radiation exposure in general when using any type of imaging modality.
So Dr. Bakari, we're going to go through the three sections of planes in cone beam software. And if you want to kind of take us through those, and we'll finish that off with looking maybe at that 3D volume. But what do you start with? We want to start with as far as which plane of view do you want to kind of talk about first?
Sure. So let's first look into the different types of planes that we have. So typically in radiology, we view three orthogonal planes. Number one is the axial, number two is the coronal, and then number three is sagittal. There's also a way that I like to actually run through the scan itself in these same planes of view. So the first one that we can look at is the axial view itself. So before I delve into that, actually, I also want to mention that we have different color-coded bars right here on the different sections, right? And the blue bar actually helps you control the axial view. So if I'm moving this bar right here, you can see right here that the axial section, we're moving through that, right? Then we have the yellow line, which helps you move through the coronal sections right here. As you can see, as I move this yellow bar, right? And then we have the red line, red indicator line, which helps us scroll through the sagittal sections. Now, this is one way that you can actually scroll through a section on a specific plane, or if you have the capability through your mouse, you can actually hover your mouse over the plane that you want to move and use the scroll button, and you can actually scroll through the view itself. So the first view that I'm going to look at is the axial view. Now, the axial view is basically, let's think of it as going from top to bottom. All right. So I'm going to use my indicator line right here, move all the way to the top. And one way that I'm going to view the axial view is from the top all the way to the bottom. And as you can see on the 3D volume rendering right here, if it's, for education purposes and actually for simplicity purposes as well, if I hover my mouse over the axial section on the 3D volume rendering, note that there is another type of indicator line, more like a 3D indicator line, that shows you where you are going through in that specific section. So as I scroll through, I'm going from top to bottom, scrolling through my axial view, and you can see that I'm slowly getting into the maxillofacial structures right here, into the maxillae, as well as into the mandible. So the next section that I'm going to briefly run through is the coronal section. And that section, basically, you can think of it as going from the front to back or vice versa. So again, one way that I can scroll through the coronal section is using the yellow indicator line and scrolling from the front all the way to the back. Now, again, another way to do it is just scrolling through with your wheel on the mouse and going from front to back or back to forth. And the other last section that we have on the CBCT is the sagittal section. So this, again, is actually not great in evaluating symmetry, as I mentioned before. But, and so in that case, you can start from the right side or the left side and go vice versa. So we're going to move to the red indicator line here, move to one side, and then scroll through the sagittal section. And like you see right here, we can only scroll through one side. So we only see one side of the osseous structures, and it's not a comparison like you can do in the coronal and axials, where you have structures on both sides and you can evaluate symmetry. But later on, I will tell you some of what I believe to be the beneficial views in the sagittal sections.
So Dr. Carr, we have our volume open here, and we've reviewed our 3 sections of view and our 3D rendering. Let's go through a workflow of where do we start, and let's define some points of keeping this consistent and really repeatable, so we can just go through each scan essentially the same way that we do for every scan, and get that into what I could almost call a habit of just, this is the workflow we're going to do.
Absolutely. It's great value to systematically review a cone beam CT volume and familiarize yourself with the general anatomy of the maxillofacial structures, get accustomed to what seems to be normal or abnormal, and understand the limitations of CBCT imaging. So systematic review of scan can vary from practitioner to practitioner. Whenever you look at a cone beam CT scan, you want to keep a consistent viewing sequence every time. And keeping such a habit actually, can then bring about efficiency and thoroughness in reading your scans. So what goes into my systematic approach? I like to take an approach that's called the global to local. This is something that, I caught on from my mentors and my fellow peers. So being in the dental field, we tend to focus on, the dental structures, rightfully so. We're dentists, right? But that might actually freeze out other structures within the field of view. And what the global to local approach does, it allows you to visualize other structures within the field of view first, and then finally localize your view to the teeth and the dental-alveolar structures. Therefore, you can make sure that you are, visualizing all the structures within the scans at least once. Starting off with the global, I like to evaluate symmetry first and the bony architecture in general. And then I work my way to the teeth, the periodontal ligament spaces, the lamina dura, and then the surrounding alveolar bone. So let's now assume that I've just opened up a scan. We have the volume right in front of us. What's the first thing I do? I like to make sure that the patient demographics, number one, match on the file and from what's embedded in your CBCT. Trust me when I say it'll save you a lot of trouble. The next thing I want to do is to make sure that the structures are oriented for symmetry. How do we do that? Let's take a look. So let's try orienting a scan. What I mean by orientation is I'm trying to show symmetry within the different planes. Now note how I go to this blue line and change its direction. You can note that the structures are changing their orientation within the sagittal as well as the the coronal as well as the axial planes. What I'm doing while I change this this blue line is making sure that the osseous structures on both sides are symmetrical or near symmetrical in appearance. What's the advantage of this? The advantage is that you can actually rule out true asymmetries in patients. All right. For example, if I'm looking at the condyle, right? The condyles here in the axial section. If the patient is not oriented properly, right? One side may seem completely different in size. And if it's not oriented, that may it'll help us. It won't help us ruling out a true asymmetry, such as cases of hyperplasia or hypoplasia. So if one condyle is truly larger than the other due to a pathology, we won't be able to truly notice that on a scan unless it's properly oriented. So again, you can change the orientations different ways on different scans. Please note that while I'm trying to change the orientation on the sagittal, right, it doesn't really make much of a difference because sagittal planes are not, they go from side to side. So it's not a great indication or a great way to try and, get the patient symmetrical. The more important planes in which you can change and actually look for symmetry or asymmetry are the coronals as well as the axial sections. So that's the very first thing I want to try to do is try and orient a scan so that the structures are symmetrical on each side.
So we've got everything oriented, and now everybody does this differently, but let's talk about that systematic and repeatable workflow of where do we start?
I like to start with the axial section. It's a great view of, from top to bottom. And, as I mentioned before, you can definitely look for symmetry in the axial scan. So what I will do is I'm going to change the layout so that our axial section is highlighted. And note that we'll still be able to see where we're going by these indicator lines on the sagittal as well as the coronal sections. So looking at the axial view first, the structures that I'm typically evaluating include the airway, the sinuses, the soft tissue regions, looking for any type of pathologies or asymmetry within those soft tissue areas. Then I scrolled my way down to the maxillofacial structures and then the cervical spine. So I start from the top. Now there's, again, two ways that you can do this. You can usually scroll through it if you have one of those rotating wheels on your mouse, or you can use these indicator lines on the side and move from top to bottom. Now, as I'm scrolling through, what I'm doing is I'm assessing them in the same way that I mentioned, starting from the air areas, the soft tissue regions, and then finally going back to the top and going through the osseous structures themselves. So right now, the darkest areas represent the sinuses. So we're scrolling through the frontal sinuses. As we go inferior, we stick to the air attenuating areas, and now we reach the level of the ethmoid sinuses and the sphenoid sinuses. Going more inferior, we get into the area of the nasal cavity and nasal cavity airspace regions. And as we scroll through inferior, we're going into the airway itself, the oropharyngeal airway to be specific. So next, I'm going to scroll my way all the way back to the top. And I'm going to go through the generalized view of the soft tissue areas. Now, as I mentioned earlier, CBCT is a victim of poor soft tissue contrast. So typically what I'm looking for is asymmetry or any type of calcifications. Another common calcification is the carotid calcifications. And, as we all know, if we go through anatomy again, you'll know there's the common carotid, the internal carotid, all that stuff. But specifically in the skull base, just posterior to the sphenoid sinuses, you may note some radiopacity, and that could indicate a calcification of the internal carotid artery. But again, whatever soft tissue we're looking at, we have to have a knowledge of where we are and what kind of calcification could occur in that area. But again, I'm scrolling inferior, and as I scroll through, I'm taking a general overview of the soft tissue regions. Again, the airway, looking for symmetry, and other types of calcifications that can occur. Again, in the neck region is the calcifications of the carotid artery. Now, I want to scroll back up to the top, and the last thing I'm going to do is I'm going to assess the osseous structures. So as you can see, we are in the region of the skull, so I'm going to assess for symmetry as well as any bony architecture. Now, for those who are asking about bony, who may have questions on bony architecture, it's basically the outlines, the cortices of the bony structures, as well as the internal pattern. So if you see a radiolucency here and it's not here, you can tell on a scan that, okay, you know what, this is a difference in bony architecture. Is it normal or is it abnormal? So I'm scrolling through. I get to the regions of the paranasal sinuses. I am evaluating the symmetry as well as the bony architecture, and I move my way down. And again, a lot of people, can evaluate multiple things. So I do like to evaluate the condyles on this, even though this view may not be the best in viewing the TMJ overall. I'll get into that later. But in general, I'm getting an overall view of the osseous structures, as well as their symmetry and bony architecture, at least once through the axial section. So I'm going to right click here, and I'm going to now focus on to the coronal section. So as I mentioned before, coronal section is going from the back to the front or vice versa. So you can go to the back, but I typically like to start from the very front, just because the anatomy in the front of the head is just so much easier to remember compared to the back, even though there's not much. But when you orient yourselves from the back, you're like, whoa, what am I seeing? So I'm going to start from the very front and scroll my way posteriorly. All right. So we're going to take the same 3 steps. All right. The air attenuating areas, then the soft tissue areas, and then the osseous structures. So as I scroll my way posteriorly, we can get a good outline of the nasal cavity and the nasal air passages. I'm looking for symmetry, as well as, any type of pathologies. The more common pathologies that we can look into the nasal cavity and the sinuses are mucosal diseases, such as mucosal thickening. So again, scrolling backwards, we are in the realm of our nasal cavity, as well as our maxillary sinuses. Side by side, we are also scrolling through the ethmoid air cells on both sides. And as I scroll my way back, we are going to enter into the area of the sphenoid sinuses and the airway. I'm scrolling my way backwards. We're still in the realm of the sinuses, and we get a good coronal view of the spine as well as the TMJs. I'm going to mention this right now. This is not my favorite view in terms of TMJs, but it gives you a good indication of the location of the condyles in this dimension, specifically relative to the center of the joint. But now we're scrolling back, and we're getting into the areas of the skull, the cervical spine. Now just imagine starting the scan from here. You'd be like, whoa, what's going on here? So that's why I usually start from the very front. But nonetheless, we're going toward backwards, and we've pretty much exhausted our air attenuating areas. Now, I will go back and start evaluating the soft tissue regions. Again, looking for any types of calcifications, any types of asymmetry, soft tissue region borders that are adjacent to the osseous structures, to look for any type of mass effects on the bony structures themselves. But again, you're looking for any type of radiopacity that might be showing up in the soft tissue regions. And I'm scrolling back into the neck regions where you will typically find the vascular calcifications, and then into the skull base and still in the neck region, looking for anything out of the ordinary. Finally, I'll go back and I will now evaluate my hard tissue structures. And again, I'm going through the scan looking for any type of osseous architecture changes or any type of pathologies. We're scrolling back through the mandible as well as the borders of the sinuses, the beginning of the skull bowl regions, and making our way back. So again, I'm going to smooch my main view. And, you know, I mentioned this before. So the axials and the coronals are the best at viewing any type of asymmetry, right? On the sagittal, you can't do that. And in a sagittal, it's very difficult to orient yourself into the scan and see where you are sometimes, you know, because again, you don't have that side-by-side view. I will do this again, and I will make sure that I am, you know, going in a certain systematic way and evaluate all that I need to. The same way that I've been mentioning, the air areas, the air attenuating areas, including the sinuses. But my favorite view for the airway is actually on the sagittal section. So not particularly the perineal sinuses or the nasal cavity, but the oropharyngeal airway space itself. It gives you a good cross-section right behind the tongue and the soft palate to evaluate certain dimensions. Now, for those who are interested in obstructive sleep apnea diagnosis and intervention, right? This is a great view to evaluate the anteroposterior dimensions of the airway. I'm going to go back towards the right side and take my same approach on evaluating the soft tissue regions. And, you know, another very common calcification that we can see is called a stylohide ligament calcification, which can be seen around this area just posterior to the mandibular rami. Again, it's something incidental, but again, you know, really great information if the patient does have specific signs and symptoms. And we are scrolling all the way towards the left side to make sure that we went through it once. So now, finally, when I go through the sagittal section the last time, I can go through, I will be going through the osseous structures. Now, my favorite view in evaluating the TMJs is actually the sagittal section. There are other ways that you can actually view the TMJs, you know, certain software such as this one do have the capability of focusing on the TMJs, so you can actually go slice by slice. But if you're going through the MPRs or the multiplanar reconstructions, the axial, the coronal, and the sagittal, you know, the sagittal is a great view to give you an overall view of the condyle, the TMJs itself, and the relationship of the condyle relative to the center of the joint as well. Moving forward, I will be going through the osseous structures as I typically do. Maybe not as much as the other sections, such as the coronals and axials, but this view is also very good and very beneficial, I believe, in focusing on the teeth. So, you know, I typically evaluate the periodontal structures as well as the periapical structures on the sagittal section. So I'm scrolling through, I'm evaluating the morphologies of the teeth, their positions, as well as the periapical regions in one arch. And scrolling through, I can see great detail on the periodontal ligament spaces, the general periodontal bone levels surrounding the teeth as well. And moving towards the left side of the maxilla, I can do the same thing. And I typically like to start again for the same way the tooth. I start from the outside, so I'm looking at the crowns, the portions of the pulp chamber as well, and then moving my way inwards towards the pulpal system and the periapical regions. So I'm looking for any type of pathology that may be associated with them, with these structures. So again, it varies from practitioner to practitioner, even from radiologist to radiologist. But the whole point is that whatever you do, you want to keep a consistent workflow so that you don't miss anything. I think that's the most important thing. You've done your due diligence by going through it once, and looking at everything in a certain way so that you keep continuing it. Hopefully it'll be beneficial to the ones who are looking at the scan.
Well, thank you for taking us through all three of our planes of view in that structured fashion. Dr. Bukhari, we did have some questions that came out of the session that we just did. And specifically the first thing I would like to talk about is when you took us through the sagittal slice going lateral medial across the image, one of the questions that came out is how do we further enhance that to focus in on an area with the software? So you and I here we've recorded some of this software clip, and we're going to kind of talk track this as we go through to answer some of these questions.
Absolutely. The best thing is that, CBCT softwares these days give you so many options on different capabilities that we can go through and, change certain aspects on the image, make the image more enhanced, see, different areas in different kind of formats. And it really gives you a great idea of like what we're looking at in different terms. So what I mean by that, for example, is you can look at the sagittal section right in front of us, right? And this is what we call like a bone window, right? So you only see osseous structures. But then again, the software gives you the advantages or the capabilities to make them, seem more apparent in some features. Like, if you want to highlight certain areas, it'll make you do that. And it's such a great tool. So right now, as we're scrolling through the software right now, you can only see bony structures at this time. All right. And we're using the toolbar right now to kind of, look through a certain scan. But what we've done here right now is angled these slices so that we have a little larger area, which is being displayed on the sagittal section. And we're zooming in now to give a more clear view of certain teeth. And you can see in that some of these teeth right now, the molars specifically, we've highlighted the periapical inflammatory processes, the periapical radiolucencies. Now, how that was done is by making the angulation on the axial section so that the lines are more parallel to the cross section. And what that has done is it made it more clear on the molar areas. So this is one of the very cool features that you get to use on some softwares, not all softwares, but specifically this one right now, so that you can focus more clearly on a certain area.
And now we're basically scrolling back lateral medial across that to enhance those areas that you just talked about. So a lot of this is really just like we're targeting a system is really when I do my trainings with doctors, we're targeting a certain area to enhance the image of the area of interest on there.
Absolutely, absolutely. You're focusing, what you're doing basically is utilizing the software to, as you said, target a specific area to make the anatomy or some kind of pathology more clear in a certain slice. So if we were to, change it back, right, and we go towards that same area of the molars, it wouldn't be as clear as if we were trying to reorient it so that the lines are more parallel. So it's again a great tool, and there are multiple tools on the CBCT softwares that you can use to enhance certain areas or certain pathologies.
Yeah, so let's go back through. I think we're switching this back to the main view, and I think now we're going to look in more of the maxilla here, and let's let this go through. We're targeting our maxilla. As you said, we're rotating that to get more perpendicular on that lateral view, and then going back. And this time what you took us through is, first look at the maxilla or first the mandible. Now we're just going to get more of that lateral view all the way across that image right there.
Absolutely.
And then another question that came up was where we can look at our 3D volume here. But one of the questions that came up was looking at the smaller 4x4 image, because right here I have a lot of anatomy and I have basically the entire skull to be able to review. But now we've switched to that smaller 4x4 image, and here we have the 3D volume. But getting that, when we go lateral medial across there, the next question is, how do I orientate that? And I think we're really, well, we are doing the same thing on this image. We're going to change this to the main window and really just adjust that sagittal slice to go down the long axis of that ridge to give us that more perpendicular view. And as we scroll through, this is what we did without orientating it. I can still see all those structures you talked about, but how do we really focus in and target that area? And I think we'll see some of that lucency there. But as we scroll across and we make those changes, we should right here, we'll be able to really see what we're trying to further enhance or focus on. So let's give this a playthrough right here. Now we're rotating that line, and now we can see more of that anatomy that we talked about.
Absolutely. Look how clear it is. Now, if we, as you said, if we're targeting a specific area, making sure that that line is going right along the ridge and the mandibular teeth, you can see as you scroll through, right, everything will become a little more clearer as opposed to going through one area at a time, one tooth at a time. So if you scroll through right now, right, you'll be able to see the teeth pretty much in one slice, or the majority of the teeth, and some of the structures as well as some of the pathology, such as the radiolucency we see in that area, as well as the inferior alveolar nerve canal that is just apical to the roots. We can clearly see the outline of that root just apical to the roots, as opposed to when you were going without orienting the scan, you could see small portions just slice by slice of the canal. But if you scroll through slowly, you will clearly see the canal just about now inferior to the roots. You can see the nice outline of the inferior alveolar nerve canal.
Yeah, I went ahead and paused this because, like I said, we pre-recorded this little clippet of the software. But yeah, you can see that nerve going right through there on there. So really, this is all just about targeting that area. So thinking of targeting what you want to see in the volume. Once you've gone through your standard 3 volume slices right there, as we target through, it's going to focus on those smaller areas that you want to see.
Absolutely.
Right. So I think next we are going to look at some of the airway tools that you talked about. I know you have a passion for airway and OSA. A lot of the softwares out there have some sort of airway tool, and this software here, right now we're kind of changing the volume around just to look at different volumetric VR renderings. But we do have a specific measure airway tool within the software. You can follow the hard palette back, and you're essentially just placing one point, dragging down, and placing your second point, and that's going to fill the volume of that the airway. And I'm going to let you talk more about, you talked about some of the soft tissue structures and that we have on there. I'm just going to pause it right here if you want to kind of talk a little bit about that airway and visualizing that from that sagittal slice.
Sure, of course. So as we saw right here, what James did was took 2 points basically in the sagittal section to get an approximation of the airway measurements. So the most superior portion that we took was at the level of the hard palate, going all the way down to the level of the epiglottis, right? And what the software has done right now, it's outlined the areas of the airway just posterior to the soft palate, as well as the tongue base. And obviously through specific algorithms, what the software has done, it's measured the cross-sectional area of that airway. Now that cross-sectional area determines whether a patient, whether it falls within a range of normal or abnormal. And abnormal airway dimensions pretty much it can predispose a patient to OSHA, or obstructive sleep apnea, or other obstructive breathing disorders. And again, it's important to note that if it falls within a range which is low or below average, right? It doesn't necessarily mean that the patient will be subject to OSA, but it can help us tell the patient or the provider, specifically sleep apnea specialist, that hey, you know what, we saw this on CBCT imaging, that the cross-sectional dimensions of the airway or even the anteroposterior dimensions of the airway are narrow, and you might want to follow up accordingly. And it's a great tool to use. There are a couple of other measurements that we like to take as well. But again, for the purposes right now, one of the most important ones is the cross-sectional dimensions, which we just measure right now. And as we can see, the softwares also have great capabilities to kind of change the outlines of the visualized structures to soft tissue structures. And through specific algorithms and things that we can use on the toolbar, right, we've highlighted the airway areas and other areas, basically, so that you have a good idea of what the volume looks like, what the soft tissue area of the airway looks like, or what the airway looks like, specifically posterior to the soft tissue structures. Again, this is done specifically through the clipping capabilities. And you get to know these things once you actually work around with the different softwares. But again, great tools, and I believe CBCT Softwares has done a great job in aiding for patients who have obstructive breathing disorders.
And this also is a good reference to relate to the patients, because they can see, this is me, see these dimensions, and then we can work with them and clinical providers to further treat that OSA, just like you said on there. We did talk about some TMJ in the session, when we looked at that large volume, and you mentioned that some of the softwares have specifically a TMJ tab or a TMJ window. I just wanted to kind of highlight this, and what we're doing here is we're really targeting the joint and being able to target that and visualize that in different windows here. So you can see we have our bar here, and this is where you can go across lateral medial, change some thicknesses and some different visualizations to look at that joint specifically. And you had talked about, position of the joint. And so here's kind of the software that will do that within this tab.
Yeah, no, definitely. What we're looking at right now at the bottom section are these serial cross sections of the right and left TMJs in a sagittal view, right? And it gives us, I think I mentioned earlier, a very good view of the relationship of the condyles relative to the glenoid fossa, right? And the articular eminence. So those are the adjacent areas to the condyle. All these make up the components of the TMJ joints. Now, as we scroll through, you'll get a good idea about how the anatomy looks like. Are there any pathological changes going on? And what are the condylar relationships relative to the center of the glenoid fossa? That was the sagittal view, but what we're doing right now is we're rotating that target area, and it gives you a nice view of the TMJs in the coronal section. And I think this is really important, looking at the TMJs in different cross sections, because it really gives you a proper 3D view of where the condyle sits within the glenoid fossa. Now, I mentioned earlier as well that the CBCT imaging, we have poor soft tissue contrast, right? So we can't really know the exact relationship of the articular discs, right? But having an idea of where the condyle sits in those 3 dimensions, right, can give you an idea that, okay, you know what? This condyle seems to be slightly positioned more medial relative to the center. So that medial joint space region is slightly narrow. There's a possibility that the disc could be displaced, or the disc might be being compressed by the condylar head. This is a lot of good information that we can use to then correlate clinically and see whether a patient is actually having some signs or symptoms. Believe it or not, a lot of patients who have even, narrow joint space regions don't necessarily have to have any clinical symptoms per se, but they could. And if they do, it correlates very well with what we see on imaging as well. Right now, we can also change up the views to give us a better idea in the X-ray form or the MIP, or the maximum intensity projection, and it gives you a good idea of how the structures lie in a more bony fashion, I'd like to say. So earlier, I did mention something about one of the calcifications that we can note in CBCT imaging, and that's the stylohide ligament. So in this MIP, where the arrow is actually on the left side, we see the arrow pointing to what is a part of the styloid process. And the styloid process is a projection, right? And off of that comes the stylohide ligament. So, we want to be careful in mentioning the stylohide ligament calcification, because a person can have an elongated styloid process and give off the impression that this could be a stylohide ligament calcification. There's a very faint line that you may be able to notice on imaging, which determines the process from the ligament. But if you wanted to localize and see where that ligament actually is, it's just posterior to the TMJ region, to the condylar head and the ramus. And right now we're scrolling through it. We can see the process right there.
A lot of information on different views and kind of targeting different areas that we want to see through the software. Kind of a recap of what we talked about today, at least in this Q&A session. We talked first about targeting specific areas to optimize the view in the 18x15, the 4x4. We looked at some pathology. We also reviewed the software specifically to OSA and that airway tool. And then we finished up here with our TMJ tab, looking at different views and projections of the TM joints through there.
Yeah, a lot of information, but again, we're hoping that it made sense. And, if not, we're always here to help. Like, if anyone has any questions, that's pretty much what we are here for. James and his team, and then me and my team of radiologists, feel free to reach out if you have any questions regarding, anything that we've discussed. Thank you so much, James, for this opportunity. I really appreciate it. It's been wonderful collaborating with you and your team. And, I look forward to hopefully, doing more of these sessions with you, as well as, my peers who were nice enough to join us today.
And lastly, again, thank you, Dr. Bukhari. Thank you, Barney and Beam Readers, for this collaboration. And thank you all for joining us today, our clinical partners out there in the field. And we look forward to connecting again in the future.
Thank you again, Dr. Bukhari and Jim. And thank you to all who joined us today. We hope this gave you a better understanding of an approach you can apply to evaluating your CBCT scans, and a glimpse into the expertise applied to every scan read at Beam Readers. Be looking for that survey email to ensure you get your CE credit for today. To continue on your personal journey and dive deeper into your 3D knowledge, please come work with us by submitting a CBCT case at beamreaders.com. Thanks, and have a great day, everybody.